Senators have uncovered thousands of secret documents revealing a shocking truth. Insurance giants systematically trained artificial intelligence to deny life-saving care to sick seniors, often without a human ever reviewing the case. This wasn't an accident. It was a strategy. How deep does the Senate's evidence go, and what does it mean for every American who needs care? The answers may upend the healthcare industry as we know it. A packed Senate hearing room fell silent as a lead investigator began reading from a cache of internal documents. Emails, contracts, and slide decks, spanning hundreds of thousands of pages. These records, obtained through subpoenas and voluntary disclosures, formed the backbone of the Senate's inquiry into Medicare Advantage insurers. Senators described a system where artificial intelligence was not just a tool for administrative tasks, but a central instrument for controlling costs by denying care. One committee member called the document Trove a roadmap to corporate strategy, revealing how executives and vendors collaborated to shape algorithms that would predict, and then accelerate, claim denials for the sickest seniors. The report detailed how vendors pitched these AI systems as a way to boost efficiency and cut spending. But inside the emails and training slides, a different story appeared. Performance guarantees tied to denial rates, instructions for staff to defer to machine recommendations, and meetings focused on managing public perception if the strategy became public. One contract excerpt read aloud in the hearing promised a reduction in medical spending, with vendor bonuses linked to hitting denial targets. Another slide deck projected millions in savings from automated denials, with charts tracking the rise in rejected claims over time. Senators pressed insurer executives to explain these findings. The hearing transcript captured the tension, lawmakers quoting from chat logs and deposition transcripts, executives repeating that AI was only an advisory tool. Yet the scale of the document cache left little doubt. For the first time, the inner workings of insurance denial algorithms stood exposed under the harsh lights of congressional scrutiny. Behind the boardroom doors, insurance vendors mapped out the future of healthcare claims. Using code and contracts, the blueprint began with machine learning models trained on years of historical denials, each data point teaching the system how to spot claims that could be rejected with the least resistance. Sales teams pitched these predictive tools as the next leap in efficiency, promising not only faster processing, but measurable savings. Internal presentations highlighted dashboards where executives could watch denial rates climb in real time, with color-coded charts tracking every dollar saved through automation. Contracts between insurers and technology vendors set performance guarantees directly tied to denial outcomes. One clause, buried deep in the fine print, made vendor bonuses contingent on reducing medical spending, a target only achievable if the algorithm delivered enough rejections. Fee-at-risk structures meant that if denial rates slipped, so did the vendor's payout. Training materials instructed prior authorization staff to defer to the system's recommendations, with override rates monitored and kept low. Some documents outlined audit triggers. If too many denials were overturned, a review would be launched to ensure staff weren't undermining the algorithm's objectives. The technical design favored speed and consistency. Incoming claims were scored by the AI, with those flagged for denial routed through automated modules that generated standardized rejection letters. Human review was often limited to edge cases or appeals, and even then, the system's recommendation remained front and center. The underlying message was clear. The algorithm wasn't just assisting. It was steering decisions, with profit incentives woven into every line of code and every clause of the contract. Margaret's daughter stood at the nurse's station, clutching a stack of paperwork that had already been faxed, emailed, and uploaded twice. Only days before, Margaret had come out of surgery, her doctor recommending a short stay in a skilled nursing facility to regain her strength. But the insurance portal flashed a denial within hours. Not medically necessary, the notice read, though none of her clinicians had been consulted. The family appealed, citing the surgeon's orders and Margaret's fragile condition. A second denial arrived, identical to the first, generated by an automated system that never saw her chart or spoke to her care team. Each time they called, a different representative read from a script, unable to explain the decision. As days turned into a week, Margaret's condition worsened. She developed an infection at home, too weak to move, while her daughter pleaded for reconsideration. The appeals process looped through more template letters, each rejection arriving faster than the last. Her primary care doctor, frustrated by the system, wrote another letter of support, but it was never acknowledged by the insurer's platform. By the time a human reviewer finally looked at the file, Margaret had been readmitted to the hospital, her recovery set back by weeks. Clinicians who cared for patients like Margaret described feeling powerless, forced to watch as algorithms overruled their medical judgment. One nurse practitioner recalled, "We'd fight every denial, but the computer always won." For families, the system's speed and certainty left no room for hope, just a series of cold decisions, delivered in the language of efficiency, that made suffering invisible. Charts from the insurer's own dashboards showed denial rates spiking almost overnight after the rollout of predictive algorithms. One internal slide, labeled with a bold red arrow, tracked post-acute care denials, climbing from just over 10% to more than double that figure in under 2 years. Management notes beside the graph called this surge a performance milestone, with projected savings highlighted in green. In a strategy memo circulated among operations executives, the language was blunt. Sustained denial activity is essential to achieving target medical loss ratios. Appeals processes should be streamlined to minimize reversals. Another passage instructed staff to delay responses where possible to reduce continuation of care. Staff training materials left little room for doubt. One slide instructed prior authorization teams to defer to system recommendations unless formal override required, setting a target for less than 2% of denials to be reversed. Supervisors tracked these numbers closely, launching audits if staff overrode the algorithm too often. In an email chain, a manager reminded the team, if denials drop below threshold, review override activity immediately. Yet, public statements from insurer spokespeople painted a different picture. Press releases described the technology as a tool for efficiency and consistency, insisting that clinicians always had the final say. But the Senate report's audit trails and internal communications told another story. Behind the corporate messaging, the operational metrics and incentive structures push staff to follow the algorithm's lead, no matter the human cost. Federal regulators responded to the Senate's findings with clear and immediate demands. The Centers for Medicare and Medicaid Services issued guidance declaring that any denial of care based solely on an algorithm, with no review by a qualified clinician, violates federal law. Agency officials required insurers to maintain detailed audit trails for every prior authorization decision, documenting both the machine's recommendation and the human reviewer's rationale. These directives left no room for ambiguity. Predictive technologies may not serve as the final word on patient care. Insurers were ordered to implement processes ensuring that every denial receives meaningful human oversight and that records are transparent and available for inspection. The message from Washington was unmistakable. Automation cannot replace clinical judgment, and the government will enforce these standards with new levels of scrutiny. Legal experts and ethicists stepped into the spotlight as the Senate report spread. Watchdog organizations raised the alarm, warning that the unchecked use of automated systems to deny care could expose insurers to federal legal action. The American Hospital Association called the practice a moral hazard, arguing that surrendering life and death decisions to algorithms strips away accountability and undermines trust in the healthcare system. Calls grew for the Department of Justice to investigate whether these denials violated anti-discrimination laws and Medicare regulations. Testimony from policy analysts made clear that the line between efficiency and intent was now blurred. Automation had become a shield for profit-driven decisions, leaving vulnerable patients at risk and insurers facing the real threat of federal prosecution. Senate investigators reviewed thousands of pages of internal insurer documents, uncovering that major Medicare Advantage companies used machine learning tools to automate and accelerate claim denials for seniors. Evidence showed denial rates spiked sharply after these algorithms were deployed, and internal memos advised staff to prolong appeals and follow automated scores, despite public statements from insurers denying intentional misuse. The data and congressional findings point to a system designed to prioritize cost savings over patient care. Regulators have since declared that AI-only claim denials violate federal rules and are demanding human oversight and audit trails. Yet many details, including the full scope of patient harm and the exact methods used to train these systems, remain shielded from public view. As lawmakers push for accountability and the Department of Justice considers further inquiry, one fact is clear. When technology replaces medical judgment, vulnerable patients pay the price. The record demands that healthcare puts humanity before profit.